We want to welcome everyone to our inaugural SiNERGe CBO Collaborative webinar. My name is Grace Bigelow, and I am the SiNERGe Project Community-Based Organization Outreach Coordinator, and will be moderating today's session. We're very excited to launch these presentations and hoping to provide the most current information on a variety of topics of particular interest to the sickle cell community. We are hoping to target a lay audience, thus having content be very accessible to all patients, family members, caregivers, and the wider sickle cell community. We've identified a variety of topics, including today's subject, helping patients adhere to hydroxyurea therapy, to cover in the series. Of course, we also welcome suggestions from all of you on topics that you would like to learn about or people that you would particularly like to hear from. Today we are honored to have with us Drs. Sohail Rana and Dr. Carlton Haywood. Dr. Rana will be our first presenter, then Dr. Haywood will present for about 15 minutes. We will open it to questions on both presentations as well as any other questions related to the topic. Okay, I am happy at this moment to introduce Dr. Rana, our first presenter presenting on hydroxyurea for sickle cell disease. Dr. Rana is a professor of pediatrics and child health at Howard University College of Medicine. He has been providing care to children and young adults with sickle cell disease for more than 30 years. He is a graduate of King Edward's Medical College in Lahore, Pakistan, and he trained at Brooklyn Jewish Hospital and the University of Rochester in New York. He joined Howard University in 1980, and he provides direct care to children with sickle cell disease and other chronic illnesses. He has been listed among the best doctors in America several times and received many awards for service to the community and research that directly benefits patients. He is currently involved in several research, service, and advocacy projects related to sickle cell and the active practice, and has an active practice, excuse me. So, with no more further ado, Dr. Rana, if you can go ahead.
Good afternoon, everybody.
Good afternoon.
Good afternoon.
Yeah, I'm waiting for the first slide to show up. As Grace said, I've been in this business for a very, very long time, and my first encounter with a child with sickle cell disease, if I can have the next slide, was actually in Brooklyn. You know, when I came to Washington, people, they listened to my accent and say, "Where you from? Where you from?" And I would say, "I'm from Brooklyn." So I own up to Brooklyn. So this was 1977, and I was an intern, and one small child, 18-month-old, with sickle cell disease, came in with fever, and he was seizing. He was having convulsions. As we learned later, he had meningitis, and unfortunately, a few hours after arrival, despite the best of treatment that we had at that time in 1977, he died. I went to Rochester soon after that, and since 1980, I've been at Howard, and over the last 34 and some, actually, it will be on August 1, 2015, it would be 35 years I've been here at Howard. So this is my community, and I've taken care of several hundred children and young adults with sickle cell disease. And I find myself very lucky that many of these children, I took care of them when their newborn diagnosis was made, and some of them are with me into their 30s. So it's a true privilege and honor to take care of this population of individuals. Actually, they have taught me a lot, pretty much all I know about sickle cell disease. We have the next slide, please. So over the last 40 years, there have been a lot of advances in understanding sickle cell disease, its biochemistry, and various processes that lead to complication of sickle cell disease. So there's a lot of science. You can fill textbooks after textbooks talking about different mechanisms, different metabolic pathways, different cells that are involved in complication of sickle cell disease. And actually, there have been more than, I would say, dozens and dozens of drugs that have been tested for treatment of sickle cell disease. Unfortunately, we have only one drug as of now that has been approved by FDA for treatment of sickle cell disease that we'll be talking about today. Could we have the next slide? So in general, the treatment has not kept pace with the science. Very briefly to review what causes the problem in sickle cell disease, it's a single mutation and it ends up in replacement of the amino acid, which is normally there called glutamic acid. It is water soluble. By solubility, I mean if you drop sugar or salt in water, it dissolves very easily, and it gets replaced by this mutation by valine, which is another amino acid, but this valine is not water soluble, and this change leads to all the complications of sickle cell disease. Can I have the next slide, please? So to explain the difference or to understand the difference, it took me quite a bit to understand it because hemoglobin S or sickle hemoglobin, which I just said has valine replacing glutamic acid, talking about the differences between sickle hemoglobin and normal hemoglobin. So sickle hemoglobin, which has valine replacing glutamic acid, is actually no different than normal hemoglobin. Sickle hemoglobin is similar to normal hemoglobin, that when oxygen is present, it is soluble. So what would be the normal hemoglobin? Take a second to think about it. Normal hemoglobins are hemoglobin A in the adults and hemoglobin F or fetal hemoglobin in the fetus. So hemoglobin S or sickle hemoglobin behaves no differently when oxygen is present. However, when oxygen is low, as it happens after blood has given up oxygen, in the capillaries, as capillary blood enters the veins, it has very low oxygen. At that level, sickle hemoglobin behaves differently than normal hemoglobin A or F. It can begin to form gel or what we call polymer, and in later stages it becomes fiber or crystal. We can have next slide, please. So we were talking about polymerization or gelling, and polymer is very much like lumps in the gravy, making the hemoglobin solution in the red cell less fluid and making the flow of cells very clumsy. Ultimately, these cells become less squishable, less deformable, and they get stuck in very tiny blood vessels. This leads to obstruction in the flow of blood, and these cells either can stay stuck, and it would lead to a full-blown crisis, or these cells can be pushed along back into the lung where they pick up oxygen, and the sickle hemoglobin, which had become gelled, returns back to normal form. Some people still have their microphones on.
Yes, and sorry again for interrupting. This is Grace again. For those of you that are participating and watching the presentations, please mute your microphones or silence your audio because we can hear you. Thank you so much.
So again, the squishability of red cell, as you know, normal cells are very squishable, very easily deformed. They are very much like Disney characters that can pass under the door. They can pull themselves and then go back into normal shape. Red cell, which has a lot of gel in it, would not be squishable, would not be able to go back to its original form. and would take on the shape of the blood vessel, and that is what leads to formation of sickle cell. Could we move on to the next slide, please? So this shows right here, if you see how the oxygen goes down in the capillary. Blood entering the capillary has a lot of oxygen. As it passes through the capillary, the oxygen flows. Oxygen leaves the red cells and is picked up by the tissue, and you see the flow slowly, slowly, slowly. Some of these cells may start forming gel, and they may obstruct the flow of blood, and this is what ultimately leads to crisis and organ damage. Could we have the next slide, please? So this is what we call sickling or polymerization or gelling within the red cells of sickle hemoglobin. That is just the start. Remember, this is the valine replacing the glutamic acid, which makes the sickle hemoglobin form gel when there is oxygen. When the oxygen is very low, when oxygen is present, there's no difference between sickle hemoglobin and hemoglobin A or fetal hemoglobin. The other players in leading to crisis are, if we can have the next slide, that these red cells which have gel, they end up getting their red cell membrane damaged, so that these cells are very sticky. They stick to the lining of the blood vessel very easily. It is even more so when child or adult with sickle cell disease has infection like a cold, and these cells would adhere or stick to the cell, and this process is called adhesion. This sticking ultimately promotes blockage of blood vessels too. Anytime there's blockage or even cells sticking to the vessel wall, this makes the white cells move into the area. Also, these red cells break down faster than normal red cells, leading to release of free hemoglobin in the circulation, and this free hemoglobin binds a very important chemical in the blood called nitric oxide. Nitric oxide is the chemical which is responsible to keep the blood vessel open, keep its shape, keep the flow going. More nitric oxide means more flow. Decreased level of nitric oxide means low flow. If we can have the next slide, please. So, in general, low nitric oxide promotes also occlusion of blood vessels, or what we call crisis. Now, imagine the traffic. Our blood cells flowing in the blood are no different than these cars on highways, and cars may break down, and there may be some sluggishness in flow of traffic, but like I say, you can't get a real gridlock until the policemen move in. Once the policemen are there, they'll have their cars sticking out, and the traffic would be a complete gridlock. So white cells are like policemen in our blood, and once they move in, they are the one who ultimately cause complete blockage and inflammation, which leads to pain for hours and days and sometimes at weeks. Next slide, please. So that was the pathophysiology, or how a change in one amino acid or single mutation leads to what we call blockage of blood vessels and crisis. This same blockage also leads to organ damage in variety of organs, stroke, kidney disease, lung disease, and damage to many, many organs, in addition to the frequent pain crisis. So here is one patient of mine who I took care of at DC General Hospital, District of Columbia General Hospital. He was 18, and he was getting admitted very frequently, as many as 100 times over the past few years. And in 1994, we had indication that hydroxyurea helps, and after consultation with Dr. Castro, who had used it on patient and in clinical trials, we started this young man on hydroxyurea. It was very modest dose, and we gave him some refills, and we didn't see him after first 1 or 2 times. And I was very worried. He would call in to one physician or other to send refills. And I called him one time and had a chance to talk to him. And he said, I don't have any pain anymore, so why do I need to see you? So he thought his sickle cell disease was gone. But this is what impressed me so much about hydroxyurea, that this patient who was having up to 15, 16 admissions a year, his pain completely disappeared, and he had a normal lifespan. Can we move on to next slide, please? Next slide, please, Grace. Becky.
Yes, doctor, I'm trying. I don't know what the problem is.
No.
Okay, here we go. Sorry about that.
Now, just a word. There's a big term called pharmacokinetics written up there. And anytime we talk about drugs and new drugs and drugs being tested, we talk about two terms, pharmacokinetics and pharmacodynamics. Can all of you hear me still? Can everybody still hear me in the audience too?
I can.
So,
Yes.
So pharmacokinetic is a term used to, when we use a drug, what does the body do to it? How does it break down? How does it excrete it? And pharmacodynamics is the other term as to what this drug does to the body. Both of these terms are very, very much need to be understood before we start using these drugs in individuals. So in general, this hydroxyurea, as we know it, it gets absorbed very rapidly when used by mouth. There's no effect of food, and we get peak levels in the blood within 4 hours. Most of it is excreted through urine, and rest is metabolized. So if patient has kidney disease, one needs to adjust the dose of hydroxyurea. Next slide, please. And this is what it does to us, hydroxyurea, and especially in patients with sickle cell disease. This is extremely, extremely helpful. Hydroxyurea increases fetal hemoglobin level. Now, what is fetal hemoglobin? It is the normal hemoglobin in the fetus, even in people with sickle cell disease. That is the main hemoglobin in the fetus. Now, fetal hemoglobin protects against sickling of sickle hemoglobin. So much so that if you had a red cell which had mostly sickle hemoglobin, even if you can put 5-10% fetal hemoglobin in that cell, that would prevent sickling of that red cell completely. So one doesn't need a whole lot. And I give the example that if you have ice on your driveway, even if you throw a little bit of salt, that ice would melt. Small amount of fetal hemoglobin does very similar stuff to sickle hemoglobin within the red cell. It prevents gelling and sickling and fiber formation, and it maintains the fluidity of the hemoglobin and keeps the red cells squishable out. So hydroxyurea, one of its main action is that it increases fetal hemoglobin, and it takes a few weeks for this effect to be achieved. Next slide. Next slide, Becky.
Yes.
Now, not all people with sickle cell disease have equal response. Some individuals do not increase fetal hemoglobin at all. Others have marked responses. But of the things that do determine who would increase fetal hemoglobin how much, the baseline, meaning the fetal hemoglobin level in that patient with sickle cell disease, they have a lot of effect on what the ultimate result would be in way of how much benefit hydroxyurea would give that patient. So Those who have higher levels to start out with, like children, have much higher increases also. Adults have modest increases. People coming from Southeast Asia, like India, Pakistan, from Saudi Arabia and Middle East, and from Senegal, they tend to have very high baseline levels. Baseline meaning that's the fetal hemoglobin they have, pre-existing, around 15 to 20%, and treatment increases it even further. So these individuals can have up to 40% fetal hemoglobin, almost completely preventing a significant problem in these individuals. Next slide, please. So that was one effect. So we talked about one effect of hydroxyurea, and as mentioned, that it takes several weeks to achieve that effect, and some individuals have very small increase in fetal hemoglobin, and others modest increase, and people coming from certain parts of the world like Senegal, India, Pakistan, they tend to have higher baseline level of fetal hemoglobin, and the levels increase in them tremendously. In addition to that, in addition to increasing fetal hemoglobin, hydroxyurea has many other beneficial effects, and one of them is that it decreases the number of white cells that rush to the site of vaso-occlusive crisis. Now, these white cells, remember, are responsible for total gridlock and blockage of vessel, but they are also responsible for inflammation and damage to the vessel wall and the surrounding tissue. So this decrease is very beneficial. In addition, hydroxyurea prevents the sticky receptors on the lining of vessel wall, what we call endothelium. There are some sticky receptors. Hydroxyurea decreases the amount of those sticky ends on the vessel wall, as well as those sticky ends on red cells, and on white cell, and this all leads to a beneficial effect that these cells, both white and red cell, don't stick to the vessel wall, and they don't damage the vessel, and the blood keeps flowing. Next slide, please. Now, this we talked about. In general, it decreases inflammation, but this effect where red cells are sticking to endothelial cell, hydroxyurea decreases that, and this effect is evident long before hemoglobin F or fetal hemoglobin goes up. Next slide, please. Now, experimental models of blood vessels have been made in the lab, and these samples from patients who either have been treated or untreated have been studied in these experimental models. So these are very difficult terms, but the term used for these models is endothelialized microfluid channels. Just imagine little pipes whose inside has been modified to resemble our blood vessels. So one can study the blood flowing through these pipes, and when untreated sickle cell disease blood is pushed through these pipes, there is decreased flow. There's tendency for the blood to slow down, occlude these pipes, and cause clotting. While blood treated with hydroxyurea treated individuals has close to normal flow. Now, these channels can be very helpful in studying future agents. Next slide, please. Nitric oxide is an important chemical we mentioned before in maintaining the blood vessel open. If there is low nitric oxide, the blood vessel tends to collapse or becomes narrow. Hydroxyurea itself is a precursor for nitric oxide. It increases nitric oxide, and this nitric oxide production may be important in maintaining health of blood vessels. Next slide, please. So those were the chemical effect. Now, what happens to actually the person? So when we have used it in a major clinical trial with controls, there is absolutely no doubt that it decreases the number of pain episodes Number one, these episodes are much shorter lasting and not as severe, even if they do happen. It decreases the chances of acute chest syndrome, the number of days in the hospital, number of blood transfusions that patient needs, number of splenic sequestration, and it overall improves the quality of life of individuals. Also, the blood counts improve, patients have less anemia, there is less markers of hemolysis that the red cell is breaking down, like reticulocyte count is lower, other chemical indices like LDH may be lower, the white cells platelet count and the cell size increases, and these all are beneficial ultimately. Also, if one starts using it early, as you remember, many of you know that children with sickle cell disease have tendency to produce large amounts of urine. Many children also have difficulty in concentrating in their urine, so even if they are not drinking anything, they continue to produce large amounts of urine, and sometimes that's associated with bedwetting also. So hydroxyurea, if one starts using it early, it tends to help kidney and it's losing concentrating ability, so that concentration ability is sustained, although it's never normal. So early hydroxyurea may help the kidney as well. Next slide, please. So hydroxyurea, I think this is an important slide. If you look at it, this hydroxyurea improves survival. That 2 long-term studies have showed that hydroxyurea actually improves the lifespan. Not only is the quality of life better, but it decreases mortality by as much as 50%. And I think this is very significant. And a retrospective study from Brazil showed the same effect in children, and collectively this data is very impressive that hydroxyurea ultimately improves the survival of individuals living with sickle cell disease. Next slide, please. Now, this is one of our own patients not too long ago. This child had abnormal flow of blood in the brain. As you all know, TCD or transcranial Doppler velocity is used to predict the risk of stroke. I repeat it, transcranial Doppler velocity is used to predict the risk of stroke. So those individuals whose velocities are more than 200 centimeters per second, their risk of stroke may be as high as 40-50% in the next few years. So this child, 3-year-old, we were taking care of him, was found to have very high velocity on his TCD. So we recommended transfusion. Initially, they were very irregular with transfusion. Subsequently, they said, no, we don't want our child to be transfused for religious reasons. We started the child on hydroxyurea. There's this misspelling, his hemoglobin increased, and 4 months later, his velocities on TCD were less than 150. He continues to benefit. His last velocity was 130, which is actually very normal. And this child continues to do very well. Not every child has this kind of benefit. Velocities on TCD improve in children who are on hydroxyurea. Okay. Let's move on to the next slide. Now, there are things about which we don't have randomized clinical trials. We know that in patients with SC and S-beta null, S-beta plus tel, there have been no randomized studies. But in cohort studies, in large group of patients where hydroxyurea has been used in hemoglobin SC and S-beta plus tel, hydroxyurea has been beneficial. Also, effects of hydroxyurea on retinopathy, avascular necrosis of hip joints or other joints, leg ulcers, pulmonary hypertension, priapism, and to some extent renal disease. We do not know its effect, whether or not it's beneficial or not. Next slide. Also, with the dosage as hydroxyurea initially got used in MSH studies, we were trying to push for maximal doses. This was a problem, especially in developing countries or in remote areas where children had to come to the clinic very often. So we had this concept of maximal tolerated dose. As of now, there's no evidence that MTD or maximal tolerated dose is needed. A modest dose of 15 to 20 milligram per kg does very well, and this prevents the need for child to come back frequently for blood testing. Next slide, please. Adverse effect. Now, hydroxyurea does suppress the bone marrow in higher doses, but in the dose we use, the effect is very modest. Low cells can happen, but they are rarely a problem. Hair loss is really distinctly uncommon. I would say less than 1 in 100. A skin rash can occur. Some children and adults complain of intestinal problems in way of abdominal pain. But in randomized studies, these effects were no different in the control group versus treatment group. Dark nails have been seen, and sometimes darkness of skin all over has been seen, but again, not very common. I would say less than 5 in 100 individuals happen. It happens. And I mentioned alopecia, it's probably less than 1%. Next slide, please. Now, what about pregnancy? Now, this is a young lady I've taken care of very long time. She got married. She was on hydroxyurea for a very long time. Never had a crisis on hydroxyurea for almost 6-7 years, no crisis. And then she became pregnant, and on recommendation of her OB, she stopped taking hydroxyurea. She started having repeated pain crisis, and at 7th month of gestation, she was admitted for one severe acute chest syndrome. She went into respiratory failure and was on respirator or ventilator for 5 days. She continued to have problem because she wanted to breastfeed. After stopping breastfeeding, she went back on hydroxyurea, and for last 2 years she hasn't had any problem, and also happily, she stays happily married. And actually, I'm looking at her picture right up there, she and her husband. Next slide, please. What about effect on reproduction? I think this is good. Can we go back one slide, please? Because this is a question that gets asked a lot. As such, as of now, I think this statement is very important, that there's no evidence that hydroxyurea adversely affects the outcome of pregnancy. All the worries come from animal data. No such effects have been proven to be true in human beings who are pregnant, but the worry remains, and most obstetricians recommend stopping. When question is asked from me, I explain. A couple of our obstetricians feel comfortable continuing hydroxyurea, and even though I'm a pediatrician, I've had over the last 10 years maybe at least 20 patients who have had babies. At least half of them were on hydroxyurea, and they didn't have a problem. What about the effect on sperms? Now, sickle cell disease does affect sperm count itself, and in mice there is some evidence that it may decrease sperm count. In human beings, effect on fertility in males is not known as of now, and this is something that needs to be studied. As of now, I do not know that there's any proof that it adversely affects the outcome as far as fertility is concerned in males. Can we move on, please? So the C word, or cancer, hydroxyurea does not increase risk of cancer in sickle cell disease. And if there is such a risk, it is so low and non-existent that the benefits far, far outweigh this risk. Can we move on to the next slide, please? Now, this is, I had these 3 young ladies who I took care of with sickle cell disease, and they were sisters. One was a stepsister, and two were real sisters. And only Amy, this was Amy here, the youngest was started on hydroxyurea in 1996 because she was having much more problems. And then she continued to call, said, Dr. Rana, I'm running out of medication. Could you call it in again? And then finally the truth come out that her other 2 sisters were stealing the hydroxyurea. Anytime they had a date, they would start taking it 2 weeks before because it decreased jaundice, and they really believed it made them look prettier. So I think this is a critical message that hydroxyurea does make you look pretty, and that applies both to men and women. Next slide. So as of now, hydroxyurea is the only medication that has been approved by FDA for sickle cell disease. Next slide. Unfortunately, it remains underutilized, underprescribed, and not available to most of the 13 million individuals living with sickle cell disease. Next slide. Even in very knowledgeable areas where there are a lot of good hospitals and good physicians, it remains underutilized. I'll let Dr. Haywood talk about it more. Next slide, please. And so, in conclusion, if you look at what is there for patients with sickle cell disease, they don't have many choices, and some choices are available only to some, like bone marrow transplant. And I end with 2 more slides. Next slide, please. Next slide. So hydroxyurea is not perfect. It's not a cure. It does not take away all the problem. Not everybody is going to respond, but good 80 to 90% of people would respond with sickle cell disease if they would take it as prescribed. And last slide. It is not ethical to hold back a treatment that has been shown to be safe and effective. I think as physicians, as providers, as caretakers, I think it is our duty to make sure that people have the information, they are able to get the medication, and we help them and support them to take the medication as well as possible. Thank you.
Thank you so much, Dr. Rana. I'd like to introduce Dr. Hayward. I have the pleasure of introducing Dr. Carlton Haywood, presenting Adherence to Hydroxyurea in Sickle Cell Disease, the Patient Perspective. Dr. Haywood is an assistant professor of medicine at the Johns Hopkins School of Medicine, core faculty at the Welsh Center for Prevention, Epidemiology, and Clinical Research, and core faculty at the Johns Hopkins Berman Institute of Bioethics. Dr. Haywood received his MA in bioethics from the University of Virginia and his PhD in health policy and bioethics from the Johns Hopkins Bloomberg School of Public Health. Dr. Haywood's research seeks to improve the quality of health care as experienced by persons with sickle cell disease and to identify ethical implications and procedures and policies that affect persons with sickle cell. Dr. Haywood serves as an advisor or consultant on a number of federal and state committees that seek to improve healthcare quality and the quality of life for individuals with sickle cell disease. And in addition to being a sickle cell researcher, Dr. Haywood is also an individual living with sickle cell anemia, hemoglobin SS disease. Dr. Haywood, we look forward to hearing your presentation. Thank you so much.
Thank you. Great. So good afternoon, everyone. It's a pleasure for me to have an opportunity to present to you all today, and I thank you all for your participation in this very important webinar. If we go to the next slide. So my objective for this presentation is really simple. We're going to talk about and review some of what is known about the perspective of those of us living with sickle cell disease concerning hydroxyurea and taking hydroxyurea. If we go to the next slide. So what do we know about adherence rates in sickle cell disease for hydroxyurea? Well, there have been a few studies that have taken a look at this. In one study of children with sickle cell disease that asked their parents, the parents self-reported a very high level of adherence. That is, the parents reported levels of adherence to hydroxyurea that range from 77 to 85%. However, when the researchers looked at actual pharmacy refill records, the rate of adherence was much lower. It was only about 49%. So it suggests that maybe there are some misperceptions between the actual rate of adherence as believed by parents and their actual children taking hydroxyurea. In another study that looked at an all-age sample of sickle cell patients that were enrolled in Medicaid that took place in North Carolina, it was found that only 35% of the individuals in the study were classified as being adherent to hydroxyurea, and this was based on their prescription recommendations and records from pharmacies. If we go to the next slide, and it's a separate study conducted here in Maryland, and one hospital-based study, out of 70% of eligible sickle cell disease patients in the hospital were actually not taking hydroxyurea. So all of these results suggest that, and as Dr. Rana implicated a little while ago, the levels of hydroxyurea taking in the U.S. are very poor, and hydroxyurea is underutilized for it to be the only FDA-approved drug approved to treat sickle cell disease. So we need to think about and figure out what are some of the reasons why adherence to hydroxyurea is poor, and what are some ways that we can go about improving those reasons. Because I'm a person living with sickle cell disease myself, I will tell you that I have taken hydroxyurea, and I've taken hydroxyurea. I took it for nearly 20 years before my healthcare providers decided to put me on a different treatment. But while I was on it, I can say that hydroxyurea really did do a number of positive effects for me in my own life and my own quality of life. And so I'm going to, in addition to talking about some of the research that we found, I'll also be happy to talk about my own particular patient perspective on it, if you would like to hear that at the end. If we go to the next slide. Now, why is it important for those with sickle cell disease to take hydroxyurea? Well, Dr. Rana outlined a number of the clinical benefits that we know that can result from taking hydroxyurea. Greater adherence to hydroxyurea has led to decreased risk of healthcare utilization, decreased healthcare costs, and a decrease in the number of vaso-occlusive events that those with sickle cell disease can experience. If we go to the next slide, this one graph just shows an example. So this graph takes a look at levels of hydroxyurea adherence and monthly medical costs as reported by a Medicaid managed care organization. And what we find is that those individuals who were categorized as having the highest levels of adherence to their hydroxyurea, they had the lowest monthly medical costs to their health care payer. That is, those individuals with high levels of adherence to hydroxyurea had a monthly medical care cost of just around $2,000, compared to those individuals with the lowest levels of adherence. Their monthly medical costs averaged just shy of $5,000, and so it suggests that regular taking of one hydroxyurea can help to improve your monthly medical costs. And if we go to the next slide, we can see that is probably most likely due to the fact that those individuals with the highest levels of adherence to hydroxyurea also have the lowest levels of inpatient utilization. So as we see here, those individuals with the highest levels of hydroxyurea averaged only about 2.4 hospital stays per month while enrolled in their Medicaid managed care organization, compared to, this is per 12 months, not per month, per 12 months, compared to those individuals with the lowest levels of hydroxyurea adherence, who averaged just shy of 8 inpatient hospital stays per 12 months. And so, again, it suggests that hydroxyurea can have a great and beneficial effect on the amount of times that we as sickle cell patients need to use the hospital to take care of certain the pain complications or the complications that may affect us. If we go to the next slide. And now let's think about and talk about some of what we know about the barriers and those things that facilitate a better or worse hydroxyurea adherence. If we go to the next slide. So as with most things, if you think about a basic model of adherence to hydroxyurea and barriers, we see that there are barriers and facilitators that take place on multiple levels. That is, there are barriers and facilitators that exist at the level of the healthcare system itself. There are those that exist among healthcare providers, and there are those that exist among us as individuals, individuals and patients living with the condition. And in this particular model, what I've shown is that one thing linking the healthcare provider factors and the patient factors is the importance of patient-provider communication. And I'm going to talk in a few minutes about how important patient-provider communication can be to better adherence to hydroxyurea and other treatments in sickle cell disease. If we go to the next slide. So when we think about some of those patient-level factors that we know can affect hydroxyurea usage, and in particular that can serve as barriers, that means that can lead to worse taking of one's hydroxyurea. In one particular study of parents of 75 children with sickle cell disease, these parents reported these factors as causing them difficulty, causing them problems in making sure that their children took their hydroxyurea as recommended. So they mentioned things such as just a number of competing responsibilities. That is, just in the process of taking care of their family and their children, there are a number of different responsibilities that they had, and some of these responsibilities could interfere with their ability to make sure their children were taking hydroxyurea as recommended. In addition, they mentioned just the challenges of dealing with sickle cell disease on a regular basis. That is, there can be so many other things that go on in the process of parents trying to take care of us with sickle cell disease, that sometimes making sure that we take our hydroxyurea as recommended can be a difficult thing to do when they're dealing with all these other challenges of having children with sickle cell disease. In addition, they mentioned there's a lack of understanding of the benefits. That is, those parents really understand why they should make sure their children take hydroxyurea. Reported not always being able to make sure children were taking hydroxyurea as recommended. So it suggests that if we can make sure that parents and patients have a better understanding as to why, that could improve levels of adherence. They also reported a barrier as in their children saying that they weren't feeling better. If you're giving your child a medication and your child is saying that I don't think it's working, I'm not really feeling any better, then this could lower that parent's enthusiasm for giving that child that medication. And finally, these parents reported a lack of social support. That is, a lack of support from friends or other family members. Because, again, they felt they had so many other responsibilities, so many challenges, they felt that if they had some support from their friends or family, then they may have been able to make sure that their children were taking their hydroxyurea as recommended. If we go to the next slide, these same parents, when they talked about those things that did facilitate their ability to make sure their children were taking hydroxyurea as recommended, those parents who said that they believed that giving hydroxyurea was a duty, that is, parents who just had the attitude, the belief that it was a duty, a responsibility, that they make sure their children take their hydroxyurea, those parents tended to have better adherence rates to giving their children hydroxyurea. In addition, those parents who said that their child actually was the one that helped to remember to take the medication as recommended, those parents who said that is, they had that active involvement from the child, said they did a better job of making sure their children received hydroxyurea. Some parents said that associating taking the medication with another regular activity like dinner, that is, making sure that if there's some regular daily activity that they did with their child, that they associated giving hydroxyurea with them at that time, then that enabled them to better make sure their children were taking their hydroxyurea as recommended. And we can understand that, right? Like, we associate it with something else that we do on a regular basis, then it may be more difficult to forget if you always give it at dinner time, if you always give it at breakfast time, for example. Finally, those parents who said that they had further discussions and or received educational materials that helped them better understand why to give hydroxyurea, those parents said that they did a better job. They tended to do a better job at making sure their children took the hydroxyurea as recommended. If we go to the next slide. And so my colleagues and I conducted a study among adults with sickle cell disease, and we tried to ask some of the same things. So in our study, we talked to 95 adults with sickle cell disease. And among those 94 adults, 39% said they had never used hydroxyurea. 24% said that they used to use hydroxyurea at some point in time, but they no longer did at the time that we talked to them. And 36% said that they were actually using hydroxyurea at the time of the interview. We go to the next slide. So among those who used to use hydroxyurea, that means those former users, 57% of those former users reported that they only took the hydroxyurea for less than 6 months before they stopped. Now, this is a problem because, as many of you may know, it takes anywhere from 6 to 12 months when you first start hydroxyurea for you to begin to see any clinical benefit to begin with. And it can also take that initial time, that is that first 6 to 12 months, just for you and your healthcare provider to find the appropriate dose for you to be on. So for those individuals who said they took hydroxyurea for less than 6 months, we might believe that they didn't really give the medication enough time to receive a clinical benefit, and or it may not have been enough time for them to actually find the right dosage that would be best for them. Those same individuals who said they took it, who said they used to take hydroxyurea but no longer did, and asking why did they no longer take hydroxyurea, the most common reason they gave was they said that either their doctor recommended it or they said that they didn't like the way it made them feel. Now, unfortunately, we were not able to unpack that doctor's recommendation. I'd be really curious to understand that one a bit better, because it could be the case that the doctor may have recommended they stop hydroxyurea for a short period of time, but many times when doctors do that, they do tell us to start taking it again. So I'd just be curious if I had a chance to talk to these people again, whether that may or may not have been the case. And then for those who said they didn't like the way it made them feel, again, we weren't able to unpack it, but I'd be curious to find out, was it that they felt like there were some particular side effects that they were experiencing that they didn't like, or if there were other kind of factors. But unfortunately, we were not able to gain that knowledge with this particular study. We go to the next slide. So among those patients who said that they had never taken hydroxyurea, 50% of them said that they had never ever received any information about hydroxyurea to begin with. So this could be a problem if people who are potentially eligible for hydroxyurea are not even learning about it, not even finding out about it. So this could be something that all of us should try to do better at, making sure that those people who are eligible for hydroxyurea actually learn medication and have the opportunity to think about it and consider it for their own treatment. Among those never users, 85% of them actually said that they thought that they would not receive any kind of improvement on hydroxyurea. Again, I'd be curious to know if this answer is due to lack of education. Talk to other people.
I'm going to interrupt just for a moment. This is Grace, the moderator, and I'm not quite sure, but someone has something going on that is very disruptive. Okay, it seems to have subsided. I'm so sorry, Dr. Haywood, if you could continue. Thanks so much.
Oh, that's okay. Thank you. Again, so in future, we'd like to kind of better understand those people who said they didn't think they would receive benefit. It'd be good if we could understand in the future just why did they believe they would. But we couldn't find that out in this particular study. We go to the next slide.
Okay.
So in the same study, when we gave the patients an opportunity to answer an open-ended question and tell us any concerns about hydroxyurea they may have had, 3 general concerns came out. One was a belief that they would have no perceived benefit from taking hydroxyurea. The other was that they said that they didn't really have enough information about hydroxyurea. And the third was there was a concern about the potential side effects. For those with no perceived benefit and concern about potential side effects, all 3 of these actually, if we could make sure that individuals were receiving access to the appropriate education about hydroxyurea, it'd be curious to see whether these same concerns would hold up, or how much could be reduced this level of concern if we could make sure that the people who really were eligible for hydroxyurea did receive the most up-to-date information about hydroxyurea and what it could or could not do. But because of these concerns, again, the belief of no perceived benefit, concern about potential side effects, or not receiving information, many of these individuals just said that they were either worried about hydroxyurea or didn't want to take it because of these three kind of general concerns. And so I think we, as a community of individuals who want to improve improve health of this population, can really try to focus on what kind of information about hydroxyurea is out there, and how can we make sure that those people who need the information have access to the most up-to-date information. If we go to the next slide. So I talked mostly about those patient beliefs or patient attitudes about hydroxyurea. Real quick, if I take a look at some of the factors at these other levels, so healthcare system factors, we know, for example, that cost of medications or co-payments can be an issue in adherence to medications in sickle cell disease. We also know that limited and or inconvenient access to clinics and limited and or inconvenient access to pharmacies can also serve as a barrier to someone being able to take their medications on time, such as the hydroxyurea. And again, these factors exist at the healthcare system, so more kind of healthcare policy interventions, in addition to community level interventions, may be needed to help reduce the impact of some of these barriers. If we go to the next slide. Finally, we're thinking about provider factors, providers who may prescribe complex treatment regimens, or providers who require a burdensome amount of monitoring. We know that that can serve as a barrier to people with sickle cell disease taking their medications on time. I want to really focus on the poor communication and lack of therapeutic alliance. So if we go to the next slide, when there's a poor communication between we as sickle cell patients and our healthcare providers, then this could have a major effect on our ability and or our willingness to take our medications and or take our medications as recommended. For example, when there's poor communication between us and the healthcare providers, we as the patient then may have a poor understanding of our disease. We may have a poor understanding of the benefit and or potential risk of potential treatments our providers want us to try. If we go back, thank you. We as patients, if we have that poor communication, we may not really understand the side effects of particular medications, or we may not understand the proper use of those medications. And with the poor communication between us and the healthcare provider, then the healthcare provider may not realize how burdensome their prescribing regimen or their monitoring regimen can be on us as individuals. So now if we go to the next slide. So I really want to make a push for the group to think about the impact of the interpersonal quality of sickle cell disease care and the impact that can have on adherence to hydroxyurea and other medications. Patient-provider communication and establishing a good therapeutic alliance between us and healthcare providers are different aspects of what it means to think about the general interpersonal quality of sickle cell disease care. Now, unfortunately, as many of you know, there are major problems and major deficiencies in the interpersonal quality of sickle cell disease care overall. And I believe then that this can be a major but not really fully recognized contributor to the problem of non-adherence in sickle cell disease. So if we go to the next slide. So I just want to propose this one model for you. This model suggests that the interpersonal quality of care can impact the level of trust that we as individuals and patients with sickle cell disease can have with our healthcare providers. And if we have this low level of trust, then that could lead to us having a low level of adherence to our medications. So as a group to think about ways to improve adherence, I want to make a push for really thinking about how we can improve the interpersonal quality of care that we as sickle cell patients receive so that we can have improved trust with our healthcare providers, and thus have that be one way that we can try to improve the level of adherence that we may have towards our medications. So if we go to the next slide. So just a brief word on what we know about strategies, general strategies to improve adherence. If we go to the next slide. So we know if you take a look at the research literature on adherence, there are 4 general strategies that are typically talked about as ways to improve adherence. So improving patient education, improved dosing schedules, increased or improved clinic hours, and improved communication between physicians and patients. And I would argue that all of these could be ways that we could try to improve the level of adherence to hydroxyurea that we see for sickle cell patients and us as we try to improve adherence to our hydroxyurea usage. We go to the next slide. And when we think about improving the communication between physicians and patients, again, I want to put in this plug for really focusing in part on improving that interpersonal quality of sickle cell disease care. That is, improving the level of care that we as sickle cell patients feel we receive from our healthcare providers. That is, to what extent do we feel like they're listening to us, or to what extent do we feel like they're respecting us and our views? To what extent do we feel like that interpersonal relationship is a positive one? And again, I would submit that the more positive that relationship is, then the better our trust is. And the better our trust is, the better our adherence could be to our medications. We go to the next slide. So improving this personal quality of sickle cell disease care, it encompasses things such as improving patient-provider communication, establishing a very strong therapeutic alliance where the patient and provider really do work as partners in the delivery of care. And I think both of those things will help to establish and reinforce trust between us as patients and our healthcare providers. So we go to the next slide. So as we close out, in conclusion, we go to the next slide. While improving adherence will require strategies that take into account all those various contributors to adherence behaviors, and again, that is the patient level, the healthcare system level, and the provider level, I think that steps to establish a stronger therapeutic alliance and improve patient-provider communication could be an essential first step that I think will greatly facilitate all those subsequent steps that need to be taken to improve our adherence to medications in sickle cell disease, in particular to hydroxyurea. So I want to thank you all very much for your time and attention.
Oh, thank you so much, both Dr. Rana and Dr. Haywood, for really wonderful presentations.
Is the doctor saying that hydroxyurea has no shown evidence of low sperm count or just a sickle cell patient in general? Unfortunately, we couldn't ask the question at that time, so I don't know what the doctor was actually talking about. Dr. Rana, are you still there?
Yes, I think that's a very excellent question. And, you know, when you look at sperm counts, there is variability within human beings and from different parts of the month. And in the scheme of things, sperm counts are not stable. Individuals with sickle cell disease have decreased sperm count as a group compared to what you can call people without sickle cell disease. However, you know, are they low enough that these individuals cannot have babies? That's a big question. Fertility is ability to have children when you're trying, and that study has not been done. Now, some individuals with sickle cell disease, when they start taking hydroxyurea, I would say the figure is about 2 in 10 would actually, after starting hydroxyurea, there would be a decrease of 10 to 20%. Number one, is that significant? Is it really due to hydroxyurea? It is very difficult to say that it is due to hydroxyurea unless you do a controlled study with one group not receiving hydroxyurea and having sperm count done, say, every 3 months or every 2 months.
At what age can a child start taking HU?
Excellent. Again, very excellent question. You know, Baby Hug, we started screening children with sickle cell disease at 7 months. And we were, of course, talking to them by screening them. So at 9 months, we started treatment. So the youngest child on study in Baby Hug was 9 months of age. Potentially, we can start 6 months. All I can say is that the safety data that was collected on first 20 patients, Baby Hug, included those 9 to 12-month patients. So there is no safety data for 6 to 2 months. Is 9-month-old baby a whole lot different than 6 months? Probably not. So I personally start, you know, when I do newborn screening, follow-up counseling to individuals with families with sickle cell disease, I actually mention hydroxyurea. And I said, you know, you will hear me, if you choose to come to see me, you will hear me talk about it at 6 months, 7 months, 8 months, 9 months, and I want we want to make Dr. Haywood used a wonderful term of therapeutic alliance. Let's get everybody from family together. I want to hear what you think of medication. So the more we let them say or talk about, how they feel about medication. Unfortunate thing is, we physicians many times don't have enough time. But even when we have time, patients think they value our relationship so much that they say something negative about a medication, we would not like them. So there's not always full willingness to speak up. But with time and relationships, they do speak up. And pretty much everybody in my clinic is on hydroxyurea. I can't make them take it.
Hi, my name is Dr. Javed Khan. I have a question to Dr. Rana. About the patient adherence. I would like to know the hydroxyurea adherence problem in his patient population and how he addressed them to improve the hydroxyurea adherence.
But I think Dr. Haywood mentioned many of the important points. I think number one is I would start with how we ask the question about adherence. I think we need to change our language. So I stopped asking, did you take your medication? That's a very stupid way that you're making them lie. So asking them, look, how do you remember to take medicine? What strategies do you use? Because it's very hard for me to remember. And letting them share that information, make it as non-judgmental, have an idea of did you have a chance to take medication today? Were you able to take it yesterday? What gets in the way? What do you do when you are staying at your aunt's house? What do you do when you go to camp? Or you're staying with your dad instead of mom? Do you have medication? So all those things and reminders and all those. But I think, even 2 centuries ago, a long time ago, I think it was Plato who said, no matter what you say or what you tell patients to do, half of it ain't happening. In general, compliance, even with that absolute life-saving cancer medication, is bordering around for oral medication between 50 to 70% at its best outside clinical trial. But if you see patients more frequently, it improves. Even in baby hug between 2 weeks and 1 month, we were seeing babies every 2 weeks, and when we went to 1 month, there was a fall off of 10% or so in adherence with therapy. So, and there's some patients who are very adherent no matter what. It's the family. But everything that Dr. Haywood said is worth its weight in gold. I think communication, support, but mostly not judging them, walking. I'm willing to walk with your shoulder. Put your arm on my shoulder, lean on me, and we're willing to walk with you no matter what. So we'll listen to you and we'll help you out where we can. Okay.
Very good. This, I really feel, has just been a very, very positive and informative experience. I thank everyone for being able to stay on beyond the scheduled time. And I do believe with that, does Dr. Rana or Dr. Haywood, do you have any final comments you'd like to say?
This was a wonderful, wonderful experience. I think getting this started, it is so valuable. I have so many contacts with sickle cell disease and so many community-based organizations on my Facebook, and they have questions. I think, number one, having this and continuing this, and
yes.
Number two is to having it archived and available.
Absolutely. Absolutely.
Truly feel honored and privileged to be doing this with you folks, Grace and Becky, and with Dr. Haywood. I've had tremendous respect for him for a very long time, and I'm absolutely delighted to be here. God bless you all. Thank you.
Thank you, and God bless you too. Dr. Haywood, are you still there?
I am. I just want to echo each and every one of Dr. Rana's comments. Thank you all for participating. Thank you for this opportunity to present to you all. And I look forward to working with all of you on future education opportunities.
Absolutely.